Right, we're live. So welcome everyone to the Defeat Diabetes Facebook Live. My name is Peter Brukner, and it's my very great pleasure today to introduce Dr. Matt Phillips, who's in Hamilton, New Zealand. Good afternoon, good evening, Matt.
Hi, Pete. Nice to see you.
Matt, we're going to talk about Alzheimer's tonight, but look, before we get on to that, tell us a little bit about yourself and what your background is. You've got an interesting accent there that doesn't sound like a New Zealand accent to me. So tell us a little bit about your journey so far.
Yeah, my accent's not much of any accent because it's a hybrid of Canada and Australia and probably a bit of New Zealand now. So I'm a general neurologist, trained as a clinical neurologist, so specializing in nerve and muscle diseases originally, but I've branched out to many other things. I do a lot of research on the side, which is probably taking up more of my time than my clinical neurology at the last few years. And yeah, I grew up in Canada, trained largely in Australia, finished my neurology training in Melbourne, where you are now, I believe. And I've been working in New Zealand the last 5 years.
Great. Okay. Now, before we talk about your research, just for our audience, tell us a little bit about Alzheimer's disease in general. What is Alzheimer's, and you know, why is it such a problem?
Well, it's quite amazing. You know, people often think that doctors, we understand all these disorders really well. However, there are multiple theories as to what Alzheimer's is, as you well know. So in my book, Alzheimer's is probably a disorder of impaired energy metabolism with mitochondria dysfunction at the heart of it. However, the current prevailing theory would be that Alzheimer's is a disorder of faulty protein accumulation within the cells, specifically proteins called amyloid and maybe tau. So there are different views as to what Alzheimer's is. So the prevailing view would be that there are too many proteins in there and they're gumming up the works and resulting in damage and death of neurons. I would say the primary issue is that neurons are running out of energy and they are dying because of that. But at any rate, Alzheimer's is basically a neurodegenerative disorder characterized by the slow, relentless death of neurons, and that leads to problems with memory and other things like attention and so on.
And it seems to be increasing. It was only in the newspapers here in Australia today that the Australian Institute of Health and Welfare put out some figures that and suggested that the incidence of Alzheimer's will double in the next 20 years or so. So, or the incidence of dementia, should I say? And obviously, just distinguish for us the difference between dementia and Alzheimer's.
Absolutely. So dementia is a clinical syndrome. That just means a set of signs and symptoms such as memory loss, which is the most common symptom of dementia. But there are multiple causes of dementia. For example, syphilis used to be a very common cause before we were able to treat it with antibiotics. Now the most common cause underlying dementia is Alzheimer's disease, which covers about 2/3 of them. So your figure of dementia doubling every 20 years would probably apply to Alzheimer's, since that's the bulk of dementia. And Alzheimer's is basically, rather than a clinical syndrome, it's a process whereby that somehow kills the neurons. And as I said earlier, I think that's probably due to energy problems and mitochondria dysfunction, but that is debatable.
Right. So obviously it's a massive problem. As you said, traditional medical teaching is that it's abnormalities of proteins in the brain, amyloid and tau and so on. And the medical professional, the medical science profession has been desperately searching for a cure for Alzheimer's for a long time. And they've tried all sorts of medications and none of them have really been shown to be of any value. So the general feeling is that it's incurable and so on. So obviously, how did you get interested in the role of diet then in Alzheimer's? Because with due respect to your profession, neurologists, they're not, traditionally very interested in diet. It's more drugs and so on. So what, you're a little bit different. Why did you get interested in diet?
It's a very good question. So when I finished my training at Royal Melbourne Hospital, I wanted to specialize in a therapy, and yet there was no real option to do so. The options were to specialize in disorders such as stroke or Parkinson's disease, epilepsy, and so on. And I didn't want to specialize in a disorder. So what I did was take some time out to travel and volunteer in Asia and South America primarily. And during that time, I really thought about how I could tackle or specialize in a therapy that could be perhaps applicable to a number of disorders. And it was a relentless search for different things. And I came up with a couple of things: fasting and ketogenic diets as being a way to do this, a way to essentially restore the mitochondria, which seem to be at the heart of the disorders, many of the disorders. And once I found that, then I came to New Zealand and decided to try and apply this knowledge, this theory, to actual clinical trials and see what happened.
Right. Well, that's a perfect lead in to the clinical trial that you've just completed or just published. You probably completed it a while ago, but take us through that and tell us a little bit about the build up to it and what the trial actually involved.
Okay, so there was a backdrop. We did a similar trial in Parkinson's disease way back that was published in 2018. And so with the knowledge from that trial, we designed a similar trial. It was a little bit different for Alzheimer's disease. And so basically the trial involved randomized crossover design, which it's a very good, powerful design, a way to analyze the impact of a diet on people with Alzheimer's. And basically what we did is we took a number of people, 26 people, and applied a ketogenic diet to half of them. And the other half, they just stayed on their usual diet with healthy recommendations from our dietitian and so on. Both groups followed it for 12 weeks. And then we had a 10-week washout phase where everyone just went back to their pre-study diet to try and wash out any effects, positive or negative, of either diet. And then we flipped the diet. So the people who had the control diet, the recommendations, healthy recommendations, they went on the ketogenic diet. And the other guys went back to the healthy recommended diet, and we followed them for 12 weeks. So, and then we compared a lot of statistics and stuff, compared everyone and saw who did better.
Right. So I guess in Alzheimer's, the things you look at are what we call cognition, and then daily function and quality of life. They're the three main sort of parameters, I believe, as I understand it. So I guess they're the three that you looked at, and tell us what you found in those different parameters from the results of the ketogenic diet.
Yeah, so we wanted to look at cognition because, of course, with Alzheimer's disease, that is affected heavily. However, when you ask people with Alzheimer's, and this is very important, it's always important to ask people with the disorder, what is the most important thing to them? That's not always done. The two things they say are daily function and quality of life. So the ability to keep doing things, perhaps at their job or with, in social situations and whatnot, and quality of life, of course. So I wanted to focus on those two things as well. So we measured all three. And we found that the cognition improved, but it was not quite statistically significant. Now, I think there was a very good reason for that, and it had to do with a very severe lockdown. Nonetheless, it was an improvement, but not statistically.
About that. Yep.
Yeah, and I'm sure most people do. It was not statistically significant, but they did improve. The other two indices, the ones that are of the most importance to people with dementia, they did improve statistically. More important, Pete, was that the improvements were clinically significant. That means the improvements were to such an extent that previous trials have shown that when you get an improvement of a certain amount, the person can tell, and people around them can tell. And I could certainly tell with a number of them, even though I was not involved in the assessment. I couldn't be because I designed it. So they improved in 2 out of the 3, and it's enticing to think that maybe if we had gone on longer, or maybe if the lockdowns hadn't done what they did, or maybe if we had more patients, we would have had a significant improvement in the cognition as well. But
so what are the sort of improvements that people would have, let's say their partner or their loved ones or their carers, what sort of improvements would they have noticed in these patients on the ketogenic diet?
So in terms of cognition, the obvious one would be memory function. So the ability to remember details of anything. The other things to do with cognition that our test measured were things like attention. So the ability to stay focused, visuospatial functions. So the ability to sort of manipulate objects within one's head and, in a visual spatial sense. Then with daily function, we looked at things. There was a whole gamut of things that we looked at. These were all looked at by formalized, well-validated questionnaires and scoring scales and tests that we had neurologists and geriatricians perform to see how the people did. So daily function encompasses things like basic things like showering and preparing meals, going out for walks, and more complicated things such as perhaps holding a conversation with someone and to what level. Quality of life looks at a whole range of things to do with, say, marriage and relationship quality and how much a person is actually enjoying the things they do on a daily basis. So really, with those three outcome measures, the cognition, daily function, and quality of life, we were able to get a snapshot of each person's life in a very broad sense. And I think that was one of the strengths of the study.
One of the criticisms, I guess, of a ketogenic diet. Ketogenic diet is a pretty strict low carbohydrate diet. It's less than probably 50 grams of carbohydrates a day. One of the criticisms is that it's very hard to stick to. That adherence is not good. So, how did your subjects in this trial, the 26 of them, I think you said, how did they go with the ketogenic diet?
In a word, 2 words, very well. So 12 weeks was the duration of the trial, and most of the difficulty of a ketogenic diet is at the beginning, in the first few weeks. 21 of them completed the diet. However, of the 5 that did not, only 1 of them had a problem with the diet itself. They had a bit of a side effect from a little bit too much coconut oil. The other 4 actually never really fully intended to do the diet. A couple of them withdrew in the first week, and the other 2 were not long afterwards. And they basically had difficulty giving up things like beer and sugar. And so if I was to do this trial again, I would make sure we ask each person with Alzheimer's, are you keen to do this? Because the reality is, I think it was the partners of those people it's such a difficult disorder. It's so difficult for people around the person with Alzheimer's that they were, in a word, desperate, and they enrolled their partner with the Alzheimer's without necessarily seeing how keen they were to do it. So overall adherence in people who actually gave it a fair shot was really good.
Great. And did they give you any indication at the end of the trial? I mean, did you ask them whether they were going to continue with the diet or not?
I did. Yes, we asked the participants and their partners, and it was just over 50% when you average the two. So 50% of the participants and can't remember, it was just over 50% of the partners said they definitely would. And then about another quarter said they might, and another quarter said they wouldn't. So pretty good.
Yeah. Okay. So this was really the first really high quality randomized controlled trial, which is the sort of the best evidence that we have. I mean, there'd been a couple of other trials, I think, just looking at the diet without controls and not as rigorous as this one. Is that fair to say that this was the first proper trial?
Yeah, it was the first randomized trial that involved people just with Alzheimer's, so no mild cognitive impairments or subjective cognitive impairments, just Alzheimer's. And it was, it was the first, it involved a fairly strict ketogenic diet rather than just a low carb diet. So we really went out of our way to try and optimize the design as much as possible. I just believe it's so important to have good quality trials when you do these kinds of studies that are potentially very contentious. If you don't have a super strong design, you're just asking to be attacked, and you're a sitting duck. That being said, you can never design a perfect trial. There's always something that you could that maybe can't be optimized. But I think we did as good a job as we could, given the resources and everything we had.
Now, I think it's fair to say, Matt, that if a drug trial had the results that this trial had, it would probably be splashed on the front page of every newspaper in the country or in the world, and that the shares of that drug company would probably go up massively overnight. What's
Yep.
been the impact? What's been the impact? I don't remember seeing it on the front page of the paper. In fact, I didn't see it in the paper at all. What's been the impact of your research, Matt?
You just hit on a much bigger topic, Pete, which I'm happy to go into if you want. But yeah, if it was a drug, you're right, it would have been heavily promoted. And I had a number of people email me and ask me why it wasn't. Well, there are many reasons. However, perhaps the biggest reason, and I'm not going to say money, obviously drug companies and so on promote products that work, and there's shares and stocks and so on involved in that. And that is a reason. Sure, it's hard to make money off a diet or strategy. However, I think the big problem is the way doctors have been trained, the way we think about health and disease is backwards. We are trained to, and this is why I left the system temporarily when I finished my training. We are trained to see everything, all these things as diseases. So like Alzheimer's is a disease, and the way to defeat it is seen as using a drug that attacks either by eliminating or suppressing bad proteins in the brain. And that's what pretty much everyone's trying to do. And I don't think it'll work, because I look at this Alzheimer's completely differently. I see Alzheimer's as a disorder, not a disease. And it's an important distinction. It's a disorder, a lack of order, a disorder that arises as a secondary effect of the true disease, which is mitochondrial dysfunction. It's a huge distinction. So mitochondrial dysfunction is not something, it's not a target you attack or suppress or try to eliminate. It's one you try to restore. You want to improve health. So the ketogenic diet is about improving brain health. The drugs, most of them, pretty much all of them, are trying to attack a disease. Does that make sense? So by attacking a disease, I don't think you're going to win. You will have short-term victories, and we have in medicine, in modern medicine. And you will be able to mask symptoms. A lot of the drugs mask symptoms a little bit in Alzheimer's. They're not great. But if you want to have a shot at healing, like disorders, like I'm not just talking about Alzheimer's, but perhaps Parkinson's, cancer, and so on, you need to find therapies that are truly healing. And doctors today have not been trained to think of it in that way, to think of themselves as being able to restore, heal things. We sort of say, oh, it's Alzheimer's, it's really tough. We try our best to manage the symptoms. And then we search for therapy, these drug strategies that destroy proteins. We've shown even if we destroy the proteins, it doesn't improve the Alzheimer's. And that's because I think the proteins are effects of the mitochondrial dysfunction too. So it's a whole topsy-turvy way of looking at medicine. And I might be completely out to lunch. I think it's important to stay humble when you have a view that's so different. However, so far I'm encouraged by the work that we've been doing and others have been doing, including yourself with your successes with diabetes. So that's a very big question, and I think I'll stop there to let you ask more.
Yeah, no, you won't get any argument from me on that. We've got everything the wrong way around, I'm afraid. I've got 100 questions for you, but what about in your own practice, in your clinical practice, Matt? You're a neurologist. You see patients with Alzheimer's disease, Parkinson's, all sorts of diseases or disorders, whichever we want to call them. I mean, do you use a ketogenic diet in your practice, and if so, for which patients? And without doing formal research, give us your impression of the response of those patients.
Okay, so I'm a general neurologist, which I really like because it means I don't specialize too much in any one disorder. I've worked very hard to learn about as many of them as I can, but I don't get biased towards, say, epilepsy or Parkinson's. I think I have a reasonably broad picture. And that's important when you have an outlook like mine that involves a therapy such as ketogenic diets, and not just keto diets. I call these metabolic strategies. So that's one metabolic strategy. Another is, as I mentioned earlier, fasting. In many ways, that's the probably the best, but we'll stick to the keto diet. So yes, I have a number of people with a number of disorders on a ketogenic diet and doing fasting protocols. Right now, in the last 6 to 12 months, I've been working very hard with people with really advanced brain cancer called glioblastoma multiforme. That is a very different disorder to Alzheimer's, very different, and has its own unique challenges. But I don't want to shy away from the hard ones. Those are the ones that we have to attack the most. Those are the ones not attack. Those are the ones we have to restore the most. The ones we have to really try hardest at. So I've got people on that. People with epilepsy, of course, I have a number of people with epilepsy on keto diet. We know that the keto diet helps people with epilepsy, and particularly really difficult epilepsy cases like drug-resistant epilepsy. I have a number of people with Parkinson's on the diet, thanks to the success of the Parkinson's trial we did 3 years ago. And so the answer is yes. I do talk about these strategies too. I try not to be too biased. I'm not anti-medication. I use medications a lot because I am still working in mainstream medical care. But when I see someone, and that's most of the patients I see with the metabolic syndrome, so they're overweight or obese, they have type 2 diabetes or prediabetes, they have high blood pressure, maybe they have an altered cholesterol profile. I do discuss metabolic strategies as well as the medications, such as fasting, such as keto diets or low carb diets, whatever the person seems more interested in. Not everyone's interested in the keto diet. And I try to incorporate a mix of strategies. I don't care how I make people better, as long as they get better. It doesn't have to be a keto diet. As long as they get better, that's what makes me sleep well at night.
Now, obviously, you mentioned my interest in diabetes, and we have our Defeat Diabetes program. What about the link between? I've heard Alzheimer's described as type 3 diabetes because we have type 1 and type 2 and so on. But I think that's a little bit tongue in cheek. But tell us about what is the link between metabolic disorders like you mentioned metabolic syndrome? Let's talk type 2 diabetes and Alzheimer's.
Yeah. So like I alluded to earlier in our talk, I think the link is mitochondrial dysfunction. Ultimately, you've got mitochondrial dysfunction in the metabolic syndrome, and you've got in Alzheimer's.
Just explain a little bit about what you mean by so to our audience who may not be that familiar with mitochondria. Well, the mitochondria, what are they, and what does dysfunction mean?
Okay, so mitochondria are the little batteries in almost all of our cells. There's hundreds or thousands of them per cell, depends on the cell. They're very important. They produce over 90% of the energy that we live on, and they're extremely important in two cell types: brain, so neurons in the brain, and muscle cells. And these little guys just basically pump energy out day in, day out, and move around the cell, and they do all kinds of interesting things. They have signaling functions within the cell. They often tell cells when it's time to kill themselves off if it's going to help the whole organism. They have roles in activating certain genes and turning others off. So they're just so crucial. And the whole idea is that these are sort of this is the essence of life. It's a lot of people focus on genetics and DNA and RNA, and no question that's important, but that's the blueprint. The things that actually carry out the life processes are the mitochondria. And when you talk about type 3 diabetes, because you did ask about that too. So there's type 1, type 2, and then some people call Alzheimer's type 3. So type 1, as you know, is where a person, it's quite a rare disorder where a person has insufficient insulin in their body. So they have to take insulin because their pancreas isn't producing it. And the insulin is needed to push glucose, which is the simplest form of sugar, into cells. Type 2 diabetes is much more common. It's hovering around 15% of the population in many Western countries. And if you include pre-diabetes, which is an early form, you've got probably combined, they're hitting around 50%. It's very common. And that one is involving insulin resistance, whereby the cells, there may be plenty of insulin, but the cells are simply refusing to be sensitive to it. So the glucose in the blood has a heck of a time getting into the cell. Now, type 3 diabetes is a brain-specific form of diabetes that happens to have features of both type 1 and type 2. It's a double whammy, and it's on the brain. So type 1, the brain does not have enough insulin there, okay? So it doesn't have the insulin it needs to get glucose into the neurons. And also the brain is insulin resistant. So it's a type 1 and type 2 situation, a double whammy, terrible. And one of the beautiful things of a ketogenic diet is it creates these energy molecules called ketones, which can bypass the insulin resistance. They don't require the same transporters. People with Alzheimer's, their brains can use ketones just as well as people without. And so that's one of the reasons they can get right in there and allow the mitochondria to create much more energy than they would normally be able to in the sort of insulin resistant, insulin deficient combination state.
Okay. So you alluded to the fact that you use a number of different therapies, one of which is a ketogenic diet. But you talked about fasting, and I think that's a fascinating topic that many of our listeners would be interested to hear. I mean, and there's different types of fasting, obviously. What do you see as the role of fasting in metabolic health and someone? How do you use it in someone with Alzheimer's disease?
Yes, thank you for asking that. In my opinion, fasting is the sole most important practice that could have the best, most impact on our lifestyle, most of the lifestyles disorders today, which are the things that are underlying most of the top 10 causes of death in the West today. So fasting, as you said, involves a voluntary cessation of food intake. So it's not involuntary like starvation. There's a difference between starvation and fasting. Fasting is able to be done in a number of ways, generally at least 12 hours. And most people would say 12 hours to a week. So you can do fasts that are 12, 16, 18 hours. And then you can do fasts that are sort of 2 days long or 5 days long, or if some people like to do 1 or 2 or 3 weeks, that's fine. I think it depends on the disorder. So you can fast in many different ways. If you ever do a fast over, say, 24 hours, please seek the assistance of someone who knows what they're talking about with it, like a medical professional. That I just got to say that. So fasting can be done many ways. And the beauty of it is it can be incorporated into any lifestyle. It does not matter how busy the person is or how stressed they are or whatever, because fasting by definition is you're doing less. So it's good on time management. It's good on your finances. It has beneficial effects. The more you do it, the better they get. Early on, you might have some trouble, but if you are with someone who knows what they're doing, they can get around those effects quite easily. Usually it's low water or not enough salt. And so fasting is a fantastic therapy. And the reason it's so good is it puts the body, when you stop eating for 12, 16, 24 hours, whatever, the longer you do it, the body goes into a repair and survival mode. The normal cells stop growing. See, we're under the impression that you have to have food 3 times a day, plus or minus snacks in the modern society. And that's completely wrong. It's completely abnormal to have 3 meals a day. It's way abnormal to have 6 or 7. The body needs time away from food to stop gorging. When you fast, your body goes into a repair mode, and mitochondria can repair most essentially, but DNA can be repaired. The cells can be repaired. There's a process called autophagy, which means self-eating, where junky proteins, perhaps the proteins in Alzheimer's that build up, can be degraded and recycled and destroyed by the cells and used for energy, because the cells aren't getting any energy from food, right? They become more efficient. Your whole body becomes efficient. And so this is the idea with fasting. I think that the power is, it's got this massively untapped potential. Of course, very difficult for a drug company to make any money out of it. So there's very little research in it, right? The keto diet, the only thing, it's Robin. I call fasting Batman, and the keto diet is Robin. The keto diet is awesome. However, it all, to my mind, the main advantage is that it puts the body in a semi-fasted state. It mimics many of the metabolic effects of fasting, including the survival repair mode, but not as well as say, a multi-day fast. So if anyone is going to do one thing to improve their metabolic health, to fight, to prevent, say, obesity, being overweight or obese, or type 2 diabetes, or high blood pressure, liver disease, fatty liver disease, non-alcoholic fatty liver disease, that is, Alzheimer's, so on, introduce some regular fasting into your lifestyle and make sure you enjoy it. And if you do, and you do it properly, you're going to just see some amazing effects. And I've just found really nice success with a lot of my patients who do this. Of course, not everyone's open to it, and there is a stigma against fasting and ketogenic diets that's very hard to overcome. And that's, I find, is the hardest thing about starting a fasting or ketogenic diet regimen is actually not the side effects of the regimen. It's the negative stigma, because it's very difficult for one person to do something without support from family, friends, doctors, and society. And that is lacking. We're told to eat all the time, and we're told, high carb, sugary snacks are promoted constantly, and so on.
So your ideal scenario is a ketogenic diet with regular fasting, maybe what we call time restricted eating. So you might fast for 16 hours every day, and then have your 1 or 2 meals that you have in that 6 to 8 hour period. I think that's a pretty popular regime at the moment, and that seems to have pretty dramatic effects.
Yes, I think it's good to combine them. There's very little evidence on fasting or keto diets, obviously, but there's very, very little evidence on combining them. But I think it makes sense to combine, say, time-restricted feeding, 16 hours fasting, 8 hours of eating, with a keto diet. One popular one I do with patients is, people who have done enough of the 16 and 8 or 18 and 6 is OMAD, 1 meal a day. And so it's not that hard. People think, oh gosh, 1 meal a day is so difficult. It's not. It's not hard at all. And it's quite good, because you only have to worry about 1 meal. And if you make that a keto meal, if you need to make that a keto meal, even better. And I think that's been successful. But it's hard to deny that the multi-day fast, when done properly, 5, 6, 7 days. I recently did a Zoom call with a fellow who went on and did a 60-day fast, 60, and he'd never done one before. Now he was, that's extreme. So I would not advocate that. However, people can fast for very long periods of time. And, if it's done correctly, it can be very, very healthy.
Right. Well, what's next? What's next for you, Matt? You're obviously, passionate about proving that your theories that many of us agree with about metabolic health and the effect of diet. You've done a trial on Parkinson's disease. You've done this trial on Alzheimer's disease. What's the next step for you?
Okay. Well, I'll just prelude that by saying it's always hard when you are enthusiastic about something, or you see something that really you think that one thinks is important and has to be done, and you have to do it no matter the resistance. You have to temper your enthusiasm, though, with objectivity. And so I try not to prove the theories. I try to test the theories and see if it actually works. I want to know if these theories, if metabolic strategies do not work. I need to know it, because I'm dedicating much of my life to it. So I want to know the truth, whether they work or not. So far, things look good, and so I'll keep going. What's next? I'm currently working with people who have glioblastoma, as I told you. I've got a few patients with a mishmash of conditions that I'm following up on an individual basis, people with things like Huntington's disease and rare muscle disorders, things like that. So unfortunately, the lockdown situation in the last year and a half that's afflicted New Zealand has really put a monkey wrench into the larger trials. I would like to continue larger trials. I have one for Huntington's that I've designed. However, the timing isn't right, because we could go into a very strict lockdown anytime, and that really makes life difficult when you're running a big trial and you have a severe lockdown situation. So I'm just doing those. I'm writing review papers, just submitted one on these perspectives. So I'm using the time to do these other things.
Great. Look, we've got lots and lots of questions from our audience, so I might start going through some of those, Matt. Louisa wants to know, if you have type 2 diabetes, will you get Alzheimer's disease?
Hi. No, it's not a guarantee. It does increase your chances of getting Alzheimer's disease considerably, though. So if you have type 2 diabetes, I really would advocate that you look into commencing a simple fasting regimen or a low carbohydrate restricted diet or so on. So it's not a guarantee at all, but it raises your chances.
Do you think the low-fat carbohydrate diet, high carbohydrate diet recommendations have contributed to this epidemic of Alzheimer's disease?
I'm going to get myself in trouble, but I believe in speaking the truth. Absolutely.
Yep, I agree.
The high carbohydrate, low fat dietary advice. I'm not anti high carb, low fat diets. For some people, they can be very effective in a certain type of person. But unfortunately, the carbohydrates that have been recommended are, well, in reality, it's a lot of sugar, but also lots of breads and grains and these large fleshy fruits have all been recommended, and fruits are full of sugar, the fleshy ones. So I think that this has contributed immensely, and you just have to look at the abject rise of type 2 diabetes and Alzheimer's disease and other lifestyle-related disorders in the last 50 years, and it correlates very well with the change in diet. There are other factors, yes. However, I think the dietary chain guidelines, the advice there has been primarily to blame.
And do you think it's reasonable to say that if someone comes and says, "Look, I've got a family history of Alzheimer's disease. I'm 45, and I desperately want to not go down that path. What should I do?" So, what recommendations would you give that person?
Yeah. So again, I'm very evidence-based, so it's difficult to make firm recommendations. Even I pick the people who might respond. Who I think a keto diet or fasting would really help. I don't just say it to everyone. But in such a person, if they had type 2 diabetes, very overweight, metabolic syndrome, and so on, then I would feel quite comfortable in helping them initiate a fasting or keto diet strategy. And I'd say do that. Now, people who are thinner, don't have diabetes, but they have a strong family history of Alzheimer's. So 5 to 10% of all Alzheimer's has a genetic basis. So someone who's 45 who actually gets symptoms at an early age, they might have a genetic basis. Not all Alzheimer's is primarily metabolic. I'm advocating that maybe 90% it is, so the vast majority of it, but some isn't. So it depends on that. If the person's underweight, I probably wouldn't advocate fasting. I'd probably try to get them on a carbohydrate restricted diet that would actually help them gain weight. It is possible, contrary to popular opinion, for people to gain weight on a keto diet if done correctly, and I have done that. So if that's what you want, people who are underweight. People who are overweight tend to almost always lose weight, which is good. So yeah, I think there's a context there. I would have to talk to this person and see what they're like and what the family history is and so on before making a recommendation. But chances are, you're right, Pete, that the best recommendation would be one of those two metabolic strategies, fasting or low carbohydrate restricted diet.
Right. We have someone else asking, what age is too late to restore the mitochondria?
That's a great question. I firmly believe no age is too late. So we used to think that, for example, as an analogy, the brain, once neurons stop being created in the brain at a certain age, neurogenesis stops, and once you have a certain number of neurons, that's it. You just lose more every year. Now we know that neurogenesis, creation of neurons, occurs in certain parts of the brain for life, and we have mitochondria that are alive and kicking around and doing what they need to do for life. So if mitochondria are damaged, regardless of the age, I see no reason that a strategy could help someone at any age. The impact might be less in a 90-year-old than, say, a 40-year-old. However, I do believe that it would help people if implemented the right way in either case.
Right. Now, here's a question after my own heart as a sports medicine physician. Have you worked with any patients with post-concussion syndrome?
I get that question quite frequently. So the way New Zealand is structured, I'm a fully public neurologist. I don't do any private work. The post-concussion syndrome people are invariably referred to the private neurology system. So that being said, I do see a few, and the problem with the post-concussion syndrome is that most disorders are not well defined, as we know, but that one is particularly difficult to define. Often the brain scan is sort of, normal, or it might show something slightly abnormal, but it's not too bad. And yet the symptoms are definitely there and they're quite disabling. So I think it's a big topic. And I guess the question relating to this talk is, would a fasting or keto diet strategy help? Potentially. However, I think there are other things that would be useful in such a situation that we probably don't have time to get into right now.
Right. Okay. let's see. Alzheimer's is a disease mainly of the elderly. Walter Longo and Jason Fung are adamant that you should not fast over the age of 70. Your thoughts about that?
Well, I have a great respect for Walter and Jason. I actually spent a week in Jason's clinic many years ago, and they're fantastic. So I have no problems. There's expert opinion and there's reality. So although, as much as I respect anyone, if they, I have put people over the age of 70 on fasting regimens, on ketogenic diet regimens, and they've done fine. So if they said that, with all due respect to them, I would disagree. And I would say that age is not a barrier. You do have to be more careful in someone, say, with Alzheimer's. The average age in our Alzheimer's study was in the 70s. Mid-70s. So you've got, it doesn't get much harder than that. People with a memory disorder who are older, who are trying to do a keto diet. And so I think you just have to be very careful with the person that you have and recognize their limitations and what can be achieved. But yeah, I don't think you should exclude people based on age.
Okay, we're nearly out of time. We have some questions about Parkinson's disease and Parkinson's trial. Do you want to quickly tell us what you found in your trial in Parkinson's disease?
Yeah, sure. So in a nutshell, that was it had more people, 47 people. The reason for that is it was a randomized controlled trial, not a crossover design. With a crossover design, you don't need many people. So that was 47 people. And Parkinson's is it's quite a complex disorder in that there's dozens and dozens of different symptoms. It's not just a tremor and slowness and difficulty walking as is often conceived. It has many other symptoms, such as cognitive dysfunction, not as bad as Alzheimer's, but it's there, urinary problems, bowel problems, difficulty eating, difficulty with blood pressure, difficulty with all kinds of different pain syndromes, and so on. So we ran a ketogenic diet. It was a little different. I think the one we used for our Alzheimer's study was superior in many ways, but nonetheless, this was a few years ago. And we showed that the keto diet improved the non-motor symptoms in people with Parkinson's. Again, the non-motor symptoms, so the non-movement related ones, are the ones that affect the quality of life much more in Parkinson's than the actual tremor and slowness and stiffness and walking problems. And you can go, I guess you could read the paper to see which symptoms improve the most. There was sort of a top 5 that we listed, but at the end of the day, they did improve, and it was quite a significant improvement. Again, clinically significant. You can go, all the papers are on a website that a patient started for me if people are interested in looking at that. So,
what's the website, Matt?
Oh, it's just metabolicneurologist.com.
Okay, metabolic neurologist. We'll put that up on our page. Sure. Fine. Last question. I've actually had 2 or 3 questions about statins. Statins, obviously, a very widely used drug to reduce cholesterol levels, and the link between statins and Alzheimer's. Are they good? Are they bad? Are they necessary? I know it's a huge topic, but briefly, do you think there is a relationship between that statins might make Alzheimer's worse, or are they not necessarily related?
I know you're asking the hard questions.
Yeah,
now.
I know. I'm sorry. So I know it's a very complex topic.
It is. So statins are, I do think that the effects are overemphasized. I think we prescribe them too much, and I would say far too much. There are reasons for that. With regards to the link with Alzheimer's, unfortunately, one of the main side effects of statins is mild memory problems and fatigue and things like that, mild muscle aches, and that of course could not only make someone with Alzheimer's have worsened symptoms, it could actually give the impression that maybe someone has a mild memory problems that is not from the statin but from something else. So it's complicated and convoluted. The actual link is difficult to discern. The reason is to discover a causal link. So like this causes this, you need a randomized control trial or a randomized crossover trial. So like in our study, we had a whole bunch of people. We kept everything the same, except one group started a keto diet, the other did another diet, and we followed them. And if they changed at the end, well, we pretty much that since only one thing changed, the diet, They had to cause the change. Now, with the statin data, there are lots of studies looking at statins and Alzheimer's and statins and this and that. They're all observational. That means they look at correlations only. So they say these people had a statin and this is what their Alzheimer's did, or how many got Alzheimer's or dementia or whatever. Now, all you can do is show associations. And you can show that statins are correlated with Alzheimer's, more Alzheimer's and less Alzheimer's, okay? There's actually, it's confusing, it's contradictory. And the reason it's confusing and contradictory is because the studies are only looking at correlations, associations. They're not able to discern causation. Why is that? Why is there no randomized controlled trial? What drug company would do that and potentially shoot itself in the foot by showing that statins make Alzheimer's worse, right? It wouldn't happen. There's no need for them to do it because they're prescribed so heavily anyways. So there's no impetus for it to happen. And it would be quite a difficult trial to design, I have to add. So I hope that sort of answers that question. That's a very big topic. There's so many big topics, isn't it? When you get underneath the surface.
Yeah, absolutely. Look, I could chat for hours, but look, our time's up, Matt. Firstly, I want to congratulate you on the work you've done. I mean, I think I do a little bit of research, and I know it's very, very hard. And to do an RCT as you did, that's a tough gig, really tough, and requires a lot of dedication and energy and passion and all those sort of things. So congratulations on that. The tragedy is that it's not more widely viewed or distributed. It really should have been on the front page of every newspaper. But I think we all know we're bashing our head against some pretty severe opposition who don't want diet to be the solution. And I think they want drugs to be the solution. So it's a challenge for all of us. But we'll keep at it. And secondly, I just want to say thank you for your time today. I know you're a busy man, but we've had a huge audience today, and I'm sure they've got a lot out of it. And we look forward to seeing the results of your work in the future. And once again, thank you and congratulations.
Thanks, Pete. I appreciate your words and for having me on the show. And I think we just got to keep forging on. Eventually, I believe the truth wins in the end, no matter how hard. And so, although yes, it was not as popularized as you mentioned, I think if it's true, eventually we'll get there.
I'm sure you will. Once again, thanks, Matt, and thanks everyone for joining us. We'll be back with another Facebook Live in the not too distant future. Thanks.